Awesome. Hello, everyone. We're excited to get started. I'm just going to wait a second for a few more people to join. I know we have a huge registration, so I want to make sure that everybody gets on, but I know we have a lot to talk about as well. So I'll just wait a little bit for everyone. As a reminder, we are the Executives for Health Innovation. Today's policy briefing is on the conflicting rules of CMS's interoperability rules and the No Surprises Act. So this is great. I guess, so I want to introduce myself. I am Emma Lloyd. I'm the Director of Policy and Programs for the Executives for Health Innovation. And today I am joined by Amanda Patnow, Managing Partner of CODA LLC, and our awesome Senior Policy Analyst, and Dr. Kevin Larson from Optum, and one of our fantastic board members. We are having our July briefing. You'll see those, we have them monthly. We'd love to have you guys here for all of our policy briefings, the conflicting rules of CMS's interoperability rules, and the No Surprises Act. So quickly, the Executives for Health Innovation, EHI, we are a nonprofit based out of Washington, D.C., and we convene executives and experts from all across the healthcare industry. And we bring everybody into a room and we facilitate important conversations about all the health IT issues. And we work together to find best practices and solutions. We are also a membership organization, and you'll see all of these members. If you see your organization on here, know that you are also a member and we want to get you involved. We have meetings and work groups and task force, and we'd love to hear from you. If you don't see your organization on here, we would also like to hear from you, and we would also like to get you involved. You can just reach out to me in the chat box. Lastly, I want to note that we are educators. We like to talk to the public, and we like to get everybody involved. So you'll see, if you go to our Executive Resource Center, which I believe my colleague Bianca is going to put that in the chat for you guys, you'll find all the information and resources and materials on all of the healthcare IT issues. This is a great database. Also, we record all of our webinars and meetings and policy briefings, so you can find this one later this afternoon if you'd like to check it out again. And before I hand it off to Amanda, I want to remind everybody that we want to hear from you. We want to know your questions. So if you could put all of your questions in the Q&A box and all of your comments and discussion in the chat. And also, if you have any resources you want to add, please do. We would love to see those, and we will also distribute those afterwards. So without further ado, I will hand it over to Amanda.
All right, thank you so much, Emma. Like Emma said, a really important part of what EHI does is convening those really important questions and conversations. And today our conversation is all around the No Surprises Act, which I think we've all been talking about or hearing about a lot, or maybe hearing a little and just having a lot of questions and uncertainty. And today we really want to dive into a number of areas, but especially around how the price transparency rule and the interoperability rules, and how some of those interact and what some of the technical challenges are. And so to talk us through this, we have with us today Dr. Kevin Larson, who is the Senior Vice President of Clinical Innovation at Optum, and formerly also spent some time at ONC, but I'll let him tell us a little bit about his background and then jump right in.
Hi, thank you, Amanda. So as Amanda mentioned, I'm Kevin Larson. I'm a Senior Vice President at Optum Health, and lead a team of clinicians in a new center called the Center for Advanced Clinical Solutions. In that center, we build clinical decision support to deploy broadly across health IT, across EHRs in the US. Additionally, I lead a lot of interoperability efforts within the United Health Group as a corporation. As many of you know, we're a very large, heterogeneous company, and we have our own needs for interoperability within the company, as well as in data exchange with our partners. In full disclosure for this, I'm not a lawyer. I'm not here to give legal advice. I did work at both ONC and CMS in the past, and but was not involved in the drafting of the rules for any of these particular things we're talking about today. As you know, there's been a large push from the 21st Century Cures time and even before that through the Meaningful Use and the High Tech Act in making healthcare data open and available and interoperable. Much of that work has focused on health systems initially, but there's now been work to focus on health plans as well. And so the policies put out by CMS and by ONC under the data sharing or interoperability rules that were part of 21st Century Cures have been in place for a few years now, making a lot more data more widely available, which has been terrific for consumers, patients, providers across the country. Then CMS mandated a couple of years ago the additional sharing of price data. So requiring hospitals to make their chargemaster data publicly available in machine readable files on their websites. And coming is the same kind of price transparency for health plans. In the middle of all of that work, the Congress passed the No Surprises Act. And I think many of you are familiar, but I'll just kind of give it broad brushstrokes from a thematic standpoint. There's been a lot of press and a number of complaints. Many of you maybe even experienced this yourself, where you go to a health system that your health insurance covers or has a negotiated rate as a tier 1 provider. But as part of that bundle of care and services, somewhere in there are services that maybe weren't covered as a preferred provider by your health plan, and suddenly you get a big surprise bill. So because of this kind of concern, there was Congress passed the No Surprises Act, which has required scheduling providers, is kind of the language that is being used by the industry, scheduling providers to submit to the insurance company all of the expected components of the scheduled procedure or the scheduled bundle of care. And within 24 hours, the health system has to return back to the patient a advanced explanation of benefits or advanced EOB, it's called, which gives the prices, the cost to the patient of that bundle of services. So an example for this might be a patient is going to have a colonoscopy, and that colonoscopy may contain the facility charge of the system at which the colonoscopy occurs, the procedure charge for the colonoscopy, but maybe there's anesthesia involved as well. So the anesthesiologist's rate would be included as well, and that would highlight whether that anesthesiologist is in network or out of network, so whether or not there is a negotiated rate by the health plan, or this is kind of fully out of pocket for the consumer. In the first phase of this deployment, it's kind of a one at a time, but there is ultimately the requirement for this to be a shoppable activity through time. A fair bit of what I'm going to talk about here is actually some of the conflicts that we've found as we've been building the standards for this work. So through a couple of what are called standards accelerators. One is called the Caring Alliance, another called is Davinci. So these are collaborations to really advance and speed up the development and testing of standards for various purposes. I've been involved in the Davinci work group that's been focused on the No Surprises Act and some of the standards that are necessary to make that happen. And in that Davinci work group, it's clear that we don't yet have a fit-to-purpose standard, or we didn't have a fit-to-purpose standard when this law was passed. And so we've had to rapidly work with multiple stakeholders to really understand how the congressional bill works, and additionally wait for some further clarification from the executive office from HHS, from CMS, about some of the details about what they're expecting. And then craft the use case, and then craft the details of how a standard would function. As you might expect for the No Surprises Act, there are a lot of challenges at every step of this process. I think most of us are really excited about the opportunity that this presents for really understanding, much like when I go to the veterinarian or the dentist to get an upfront estimation of what it's going to cost. But our current system is not engineered for this, and therefore the interoperability, the transaction standards are not engineered for this. So what do I mean by that? Well, typically, the charges go through a whole lot of rules within a rules engine at a health plan, like the one that we have at UHG, the United Healthcare System. We actually have many, many different claims adjudication systems. And so a claim will come in and it runs through really hundreds of different rules until finally, after it's processed, we understand what the negotiated rate was. We understand whether or not all of the services rendered are actually covered services. We understand all the pieces and parts, and therefore can adjudicate that claim and say, this is what the health plan costs are, and this is what the patient costs are. And those transactions, as many of you know, are typically done through a standard called the X12 standard, which governs a lot of the claim standards. And those are the back and forth between providers, billing systems, and health plans. However, the clinical systems are typically what, in advance of a service, have determined what the care plan is, what are the bundles, and those clinical systems, the interoperability systems, electronic health records, will speak this X12 language through their revenue cycle, but they don't actually speak it in real time typically. For things like scheduling and care plans, those are all done in HL7 standards, often in what are called HL7 version 2 standards, or more and more in FHIR standards, fast healthcare interoperability resources, which are API and more modern. So a lot of the work that's been done on the price transparency rule has been to look at the standards that exist and then figure out what is exactly the workflow that we can expect nationally for the scheduling provider to put together the set of expected services, and then send that over to the health plan for the health plan to run an advanced explanation of benefits to give back to the patient. A few of the things that we've run into is that there are actually two different kind of proposals that have been worked out, one by Davinci and one by Karen. And those two different proposals we're working hard to integrate those two proposals into a single path forward. And that's looking like it will work. There's also been work to understand how much of this is done in X12 versus how much of this is done in HL7 FHIR. A lot of the people that we talk to on the EHR and interoperability side are very interested in doing this as much or entirely in FHIR as possible. However, the health plans are all built to X12 exchange, and the cost and refactoring for that kind of X12 exchange is really, really high. Additionally, and this is where we get to a little bit of this conflict, when you're posting your prices, either as a health system or as a payer, those are going to be some kind of general generic price, like your charge master. Or your general price that you'll pay as a health system. The expectation in the No Surprises Act is that we'll actually give you the adjudicated or the negotiated contract rate that you individually specifically will have. Now, both of those things are possible, but there is some concern within the industry that if I'm a consumer and I somehow have access to the general rates for something, and then I get an advanced explanation of benefits about the specific rate I'm expected to pay, who and how is going to resolve that kind of difference in between what I see as a general rate and what my health plan negotiated rate looks like. It's also unclear who are going to be the organizations or the technologies that integrate that information directly to consumers. So there's a lot of work in this space, a lot of interest on the further rulemaking that CMS will have, but a fair bit of kind of anxiety on behalf of, I think, most of the players involved, that will be able to effectively and accurately do this exchange, get the appropriate bundle, get the appropriate set of services from the anesthesiologist with the anesthesiologist rates, pass that over to a health plan within just a few hours, so the health plan can then have 24 hours to run it through some kind of new sort of claims adjudication to spit out this response. People are working hard to make it happen, but it's a big change. So I've gone over my 10 minutes, but I'll pause there and kind of open for questions and dialogue.
Yeah, no, that's great. Thank you, Kevin. A lot of technical details to think about and talk about for sure. And we do have a few questions in the Q&A. I think a number of the things that I'm seeing and hearing that you kind of touched on are from a patient perspective, we all think it sounds great to have really clear pricing and information. But you mentioned already some of the difficulties around the different claim standards and how complicated those are. And one of the questions in our Q&A sort of takes a slightly different look at some of those complications, saying that, thinking about like an anesthesia example, which you gave, how does that work when the professional fees from the group that you mentioned, like the anesthesia group with credentials of the hospital, are separate from the hospital surgery center and all of those charges?
So our understanding is that it's the responsibility of the scheduling provider. That's kind of what we had to work out. So whoever is going to be scheduling that procedure, so presumably in this instance, that's the hospital, they have to understand what the rates are by that anesthesia group. And the health plan has to be able to give back the expected health plan portion of that anesthesia rate, which will be determined on whether or not that health plan has a negotiated rate with that anesthesiologist, if that's negotiated separately from the hospital. So this is some of the complexity to these questions. You can imagine some procedures may get even more complicated. You could add in a radiologist fee that is a separate radiology group from the hospital and the surgeon and the anesthesiologist. And so suddenly you could imagine exploding complexity with complex procedures that have a number of different medical professionals from different places with different negotiated or non-negotiated rates with the health plan. This is really to get at the out-of-network provider. That's a surprise, but it casts a broad net to get at many of the providers that will be, or all of the providers that will be billing under that same procedure bundle.
Great. And when we're thinking about those procedure bundles, I'm curious if you can give us a little bit more visibility, if possible, into, how do we think the providers are going to know what is the bundle of procedures that fall into one episode of care?
That's a big question. And I think a number of us that are clinicians that have been part of these work groups are concerned about that. It is not called out in the standard, and it's called out as an expectation in the law, but there's no particular, there's nothing in particular that draws upon. So currently it's going to be the responsibility of whoever is that scheduling provider to articulate in advance of the procedure, here are all of the expected components of this procedure that may have independent charges. And so it is entirely, the burden is on that scheduling provider. Many of us assume that we will be using different kinds of bundles. And so, I was the CMIO of a health system, and for all of our surgeries, we had an order set, and we had a provider provider cards, they called them, for the surgeons that listed out for this surgeon, this is what that surgeon would typically use. And so we would have those things built and stored in our electronic health records, and presumably would then send that as a package. I personally feel that this is going to be hard for many small providers who don't have an IT system that has those kind of predetermined sets and electronic bundles. They will have to be able to send this just as anyone else. My understanding is this doesn't just apply to things like surgeries. This applies to any scheduled procedure. So this could be a primary care visit. This could be a lab visit. This could be a visit to physical therapy. All of those things will require this same kind of understanding by the scheduling provider. What are all the pieces and parts that then get shipped off to the health plan?
So many questions still, for sure. So you were talking a little bit earlier about the Davinci standards development, and we have a question in the Q&A that asks, does this include a query retrieve based approach that requires payers to respond on applying where a member may be on their deductible, or breakout facility versus professional versus imaging testing fees? And are there standards that are being developed to map the variation benefit plans to a patient's individual EOB, but before the service?
So the last one I can answer really straightforwardly, yes. So those standards are being developed. There has been an X12 standard that can do this, that is being kind of hardened and made more comprehensive and specific. A lot of groups are working very, very quickly to do this all in FHIR. And so there are a lot of the FHIR standard is actually built out. And so that is a query-based approach, as many of you know, an API query-based approach. And it's more than I know to that actually that it will articulate about whether or not where the member is on their deductible. That's certainly the way this works for pharmacy billing, as many of you know, that because of the CMS donut hole and other things, when you get an estimate through the pharmacy kind of advanced estimate systems, that is accounted for. My memory of this, but again, don't quote me here, my memory is that that's not specifically called out in the legislation, and this is really just a advanced estimation and benefits. And I would assume that there will be people that work on figuring out very specifically what is the likely cost. One of the things we've talked about in the work group is whether or not we have to put a time dependency in this, because you can imagine if I'm scheduling a procedure today for a procedure done in December,
Sure.
I may be in a very different place deductible, or even worse, let's say I'm scheduling it for January, suddenly the new calendar year is here, and none of my deductible is used yet, so I will have a much higher deductible for a January procedure than a December procedure.
Right.
My understanding is all that is not yet worked out, and so there's going to be some variation here at the beginning until it does get worked out.
Sure. And it looks like we've got time for at least one more question here, which I think is a really great question. The question that has come up from Linda Rowe is, do you anticipate that CMS will do additional rulemaking to clarify some of this?
Yes. Again, we've had CMS come to our Davinci work groups and talk about this. These price transparency rules, the prior authorization burden reduction rules, and the No Surprises Act rules share a number of components, I think, in part about how do we represent these kinds of coverage, claims, and cost information in standards, and what's the expectation from a timing, from an availability, from which standards body to use. And so CMS has been very responsive and listening carefully to the Davinci work group and the members on those calls, as well as many others, and are hearing that more clarity would be really helpful. So they, of course, don't signal anything in particular, but the way that typically this works is Congress enacts a law, And then HHS and its designees like CMS ultimately fill out the details of that in regulations. So there's every reason to expect that CMS will weigh in and give more detail for how they expect this to work. And from my time in government, I can say that they like to point to mature standards for this exchange as opposed to pointing to things that are not tested or not used yet. So some of it is a kind of collaborative, let's build this, let's test it, let's find what really works. And then once the industry has established a path that really works, it may be that the government would say, point to that standard and say, okay, here's how we think it should work. And 20% of you have adopted it. We expect the rest of you to adopt it by such and so date. We don't have that signaling necessarily from CMS yet, but I would expect those kinds of signals or that kind of activity to play out. That's really how a lot of these others play out through time.
Fantastic. Thanks for that, Kevin. And before we wrap up today, any last recommendations, comments, or consolations that you can offer?
Well, I think this is going to be hard. I think everybody knows this is going to be hard. I keep thinking how fantastic this is going to be for consumers. And I think there's a lot of opportunity for people to get ahead of the curve here and really build tools that both give their patients transparency and their patients' ability to make good choices about what they want. And also to be able to highlight your ability to meet people where they're at with cash payment. I can say when I was at a health system in Minnesota that served a lot of people that were cash pay because they were uninsured, when we could give transparent prices and negotiate up front about what the payment schedule would look like, we had a lot more, we had a lot less bad debt from the same exact procedures and the same patients than we did when we did all this at the end of the game. Because what would happen is we would present them with this gigantic bill and it would just look scary and crazy, and they would ignore it and wouldn't pay anything at all. If everything was pre-negotiated up front, most people were interested and willing to pay, and they paid a portion of this. So I think this has great opportunity for health systems to eliminate some part of their bad debt by getting in front of this and doing what most other industries do and set people up on a payment plan and say, this is what we expect the overall charges are going to be. There is something else that's come up from the Davinci work group that's a concern, which is the only person right now that gets this advanced explanation of benefits is the patient. There is no requirement under the law for that to come back to the provider or any of the other providers that are part of the procedure. So we're thinking that some systems will build a pathway that it's not only the patient that gets the estimate, it's the provider as well. And looking forward to this shopping experience, which could be a big game changer in healthcare. If I can have an Expedia of colonoscopies and understand which places charge how much based on my insurance, that could really change how people choose their care.
Sure. And I think the point that you made about health systems eliminating bad debt is probably going to be a really important one too. I know that that's something that they're constantly looking at right now.
Yep.
Fantastic. Well, Kevin, thank you so very much for your time, and thank you for all who joined us today. And we'll look forward to seeing you on our policy briefing next month.
Thank you very much. Take care.
Thanks. Bye-bye.
Bye-bye.